So I will provide some brief backgrounds on our two presenters, and then we'll invite them to take over and start their presentation. So first up, we are very, very fortunate to have Dr. Elizabeth Waybright, who's an associate professor in the Department of Human Development and Adolescent Extension in the Youth and Families Program Unit at Washington State University. Dr. Waybright is currently, I think, physically in San Diego on sabbatical, so we're very happy to have her locally. She co-directs the SAMHSA-funded Northwest Center for Rural Opioid Prevention, Treatment, and Recovery. And she has a background in adolescent development and prevention science. Her work spans basic research on topics including adolescent experience, behavior, to adaptation, implementation, and dissemination of community-based substance use prevention and positive youth development programs, and efforts to build capacity among professionals and systems for delivery of evidence-based approaches. We have, I'm sure we'll learn more from you, Dr. Waybright. I'll next invite us to share a bit about Dr. Samantha Harden, who is the director of the Physical Activity Research and Community Implementation Laboratory within the Department of Human Nutrition, Foods, and Exercise at Virginia Tech. Dr. Harden has 12 years of experience leading and participating in research practice partnerships for healthy lifestyle interventions across various populations for chronic disease prevention and management at the individual and systems levels. Dr. Harden is an expert in using and applying the REAIM framework, and also is currently working on publishing and promoting a book on how to integrate yoga and mindfulness principles in academia. So stay tuned for that. So I think with that, we'll go ahead and stop sharing, and we'll turn it over to both of our presenters.
So thanks for coming today. I'm excited you're here. You can see there's kind of a nautical theme. So that's carried through the presentation. It was fun to Google nautical terms. So you'll see that as we go throughout. But let me go ahead and get started. All right, so here's kind of what the presentation is going to look like. We'll do a brief overview of land-grant institutions and cooperative extension, and then we'll really each share implementation and dissemination examples from both of our experience as extension specialists at our institutions. But then we'd really like to have a conversation and engage you all in how do we apply dissemination and implementation both with and within our extension network through a SWOT analysis. So this is a little bit of a cue as we go through the presentation to be thinking of strengths, weaknesses, opportunities, threats to bring into that conversation at the end. And I think this could be really helpful for Samantha and I to kind of potentially guide future work or inform kind of what next steps are to integrate dissemination, implementation, and extension in new ways. So I want to first provide an overview of the land-grant system. And this is a really zoomed out image of the United States, but I want to point out that there are really three points in time in which we have introduced institutions, universities into the land-grant system. So 1862s were the original land-grant universities. Washington State University, Virginia Tech is in those, and I'm happy to put the link to this image in the chat so you can zoom into a different state if you would like. In 1890, they are historically Black colleges and universities were added as land-grant institutions, and 1994 is our tribal colleges. So I want to acknowledge all of this, that this land was not just up for grabs, sitting there unused, that there were Indigenous individuals residing and using and engaging this land in ways that were important to them, and the land was really taken from them to be given to land-grant institutions. UC Berkeley has a really nice report on the UC system land grab. However, there's also a website that we can put in the chat that has an interactive map where you can see who was residing on the land that a given land grant was in. So a couple of resources to check out. At the higher level, this image is from the United States Department of Agriculture, but it really exemplifies the unique structure of the land grant institution and extension system, that it is this interesting federal, state, local partnership that you don't always see other places. So we have these national connections, and USDA is an example of that, and other associations that are within USDA. We have the land grant institutions, which have academic departments like where Samantha and I reside, but also research and experiment stations, and then the cooperative extension system that they fund. And then at the county or regional level or county equivalent, if you're in Louisiana, we have local offices, often an office in every county, and some tribal offices. We have one in Washington State, which house local faculty or staff as well as volunteers. So in Extension, we have this funding model where we get federal funding, state funding, and often local county funding. So this idea of diffusion of innovation isn't new to Extension. And I went to the Dissemination Implementation, to the meeting a couple months ago, and why is the name escaping me, of the collaborative? I apologize. Maybe someone can put it in the chat for me.
CIRC.
CIRC, thank you. I had DISC in my mind and not CIRC. Society for Implementation Research Collaborative. And I was really excited to hear how much emphasis was on community-based work. And so really connecting back to the origin and the roots of Extension, this paper on the left that you see is from 1963. And then we're still talking about the diffusion of agricultural innovations. The paper on the right is from 2021. However, I think maybe one of the newer areas or avenues in which we've used dissemination implementation science is health. So rocking the boat might be a little strong of a term, but we're really trying to expand dissemination implementation science into public health. And I really appreciate this 2018 paper from Estabrooks that gives you what this could look like, or if you're new to D&I science, how you could be doing this. And so here's the table from that paper, which gives you some very clear action steps for where you could start and what this could look like. And this has been really helpful for me. However, we also have some parallel things happening at the national extension level, kind of like ships passing in the night. They're not happening in collaboration, really. They're just happening side by side. So in 2014, Extension made this national health and wellness framework. I would say they have kind of a 2.0 version that came out in 2021. And so this is an overview of what that framework looks like. They have these 5 recommendations that are listed along the left-hand side, but this whole framework is, I would say, pretty much made kind of separate from implementation science. And I think it's going to take an interdisciplinary approach to really enact this framework at a broad level. So there are a lot of opportunities for integration going forward. So let's jump into some of these examples, or a tale of 2 journeys. So there was already a lovely introduction. Thank you to myself at Washington State University. It was mentioned that I co-direct our SAMHSA-funded Center for Rural Opioid Prevention, Treatment, and Recovery. And we just got another round of funding to expand that to serve all of SAMHSA's Region 10, so we're calling it Northwest. And then I also run, usually when I'm on campus, but from afar right now, run the Adolescent Health Promotion Lab, where we engage students in a lot of this work. I want to give a couple examples. So as an adolescent specialist, we often brand the projects especially when we're engaging teens and youth, to make them more exciting and help them feel like they really are a part of something. And so these are just a couple of examples. The one on the right, you can clearly see is 4-H branded, and I'm going to come back to that project in a moment. So my background is not in implementation science, and I want to be upfront about that because I kind of found my way here by necessity. But I realize as I reflect back on my own learning and progression that maybe it wasn't all new to me, even though maybe coming to implementation science felt a little overwhelming. My background is really in recreational therapy. That's what my undergraduate and master's degrees are in, which is using recreation and leisure as a means to help promote the health of people with disabilities. And usually you'll find recreational therapists in clinical types of settings. I'd worked in inpatient psych and long-term care. But we follow this, what was to me called the API process, or how I learned it. So it's a very individualized process of doing an individual level assessment, an individualized treatment plan, doing an individual, you might put people into small group intervention, evaluating, and then kind of coming back to the beginning to see how did we meet those goals? What do we need to change? This often meant working on interdisciplinary teams or co-treating with occupational or physical therapy. When I got to graduate school at Penn State, I had a pre-doctoral fellowship, was a T32 grant funded by NIDA to participate in what was called the Prevention and Methodology Training Program. So I really got to understand prevention science. And these are from the current standards of prevention science. And I want to acknowledge those are being updated. So these fields may change going forward, but for now, it's really epidemiology. What is the health outcome, related risk and protective factors, moderators, et cetera. That's all used to inform development of an intervention, then implementation, and then testing efficacy and effectiveness of that. So when I realized I needed to learn more about implementation science, and I'll talk about how I got to that point in a moment, it felt a little overwhelming. There are a lot of frameworks, and although there are some amazing websites to help you sort through those frameworks, which were really helpful, I turned to the National Cancer Institute, the NCI Implementation Science at a glance, and found this. And I was like, oh, assess, prepare, implement, evaluate. I've got this. Like I can see the themes, even though these are very different disciplines, there's a logical process that we're following in all of them. So I felt comforted or validated that maybe I did already know something and it wasn't all coming from scratch. So when I arrived at Washington State University in 2014, I realized I was the first person hired in human development in a split extension appointment role. And I had to figure out what the heck I'm supposed to do. I want to orient you to just at least the organizational chart at WSU, because it looks different at each institution. We have some folks in the meeting from the UC system, which also looks very different. At WSU, we have our provost who oversees our deans. My dean is I'm in the College of Agricultural, Human, and Natural Resource Sciences, where we have multiple associate deans. One of those is also the director of extension, who oversees those extension program units. For example, I mentioned earlier the youth and families unit. And within those units are then faculty, staff, and at the local level, coordinators. So extension program units are really similar to departments. And so we have department chairs, and in that red box is where I fall. I am a faculty in a department, but also affiliated with an extension program unit. And I work closely with the faculty and staff there. So when I arrived at WSU, I realized I just needed to start talking to people. I'm new and on a tenure track, and I'm trying to engage in community-based work, and I'm starting to develop these local relationships, but I'm also on a tenure track and I have to move some projects forward. So there's this tension of the length of time it takes to engage in community-based work with needing to get publications out. So I really went back to filling some holes in prevention science. I published on, for example, here's a paper about reasons for using alcohol and doing a latent class analysis to identify subgroups most at risk and how these subgroups are associated with consequences of alcohol use, and then how they differ by male and female. So really still informing intervention development, but more basic research that is separate from communities, often using secondary data. And at the same time, we're trying to leverage some of these projects that are funded. An example, this was funded by National 4-H Council, but these are programming grants. There's no expectation of research. And so here we were engaging teens as teachers to deliver a nutrition education program to younger children. And I was really interested in what outcomes do we see among the teens, which was never a part of the original program. That wasn't a question asked by the funders. And so we managed to leverage this project for some research. Now that's kind of consistent with the way other projects are funded in extension. So there's a number of funding mechanisms that are only open to land-grant institutions. A lot of those are from USDA, and they don't have to necessarily do with nutrition. So if your mind went there, I understand. So let me give you a couple of examples. So I'm the PI on a couple projects funded by USDA, the Children, Youth, and Family at Risk one, and I've highlighted the purpose here. The intent is to develop and deliver educational programs. Another mechanism that I have funding from is the Rural Health and Safety Education. It is funding individual and family health education programs. You can see this is the implementation of programs. Then we have funding from SAMHSA, like I mentioned earlier, to fund that center, now the regional center. And this is to develop and disseminate TTA, or training and technical assistance related to opioids in rural communities. So none of these are research projects. And so I think it really presents a nice opportunity for implementation, dissemination science to be working with land-grant institutions and leveraging these programming or TTA funding mechanisms for additional research on top of that. So let me give you an example of what that's looked like and how I've had to come to implementation science out of necessity at WSU. So at Washington State University, we have a long history of implementing a program. It is a family-focused substance use prevention program called Strengthening Families Program for Parents and Youth 1014. That's a mouthful. So we usually call it SFP 1014. The intent of SFP, it happens across usually 7 sessions. It's structured so that the first hour, parents or caregivers and their youth separate. The second hour, they come back together and they practice some of these skills. So the idea is to strengthen family relationships and long-term reduce youth substance use. There is a lot of evidence to support this program, so it's great to implement within our state. We already do a lot of things with this program. We have extension coordinators who are facilitators, provide direct program delivery. We already provide training and technical assistance. We have an SFP 1014 community of practice. We have a faculty member who is a master trainer in the English as well as the culturally adapted Spanish language version, who has contracts to provide training across the state. And then we provide kind of a fee for service program evaluation where local sites can submit their pre-post data. We will analyze it, give them back a site level report. They can use that for their purposes and needs. And then we can use the information they provide for additional research. Now, the funding mechanisms I mentioned are really supporting program adaptation. So we heard from the community, we love SFP, but we're hearing from our families that we want substance-specific content, which the current program does not include. So in Washington, we're a state of legalized cannabis. And the thought was maybe we should be adding cannabis-specific content. Families, parents have a lot of questions about how to handle this, and we should add it to SFP. Where do we start? There are a number of adaptation frameworks, and some of them guided our work, but it was really helpful to start with this paper, and whether you can find a scoping review, a meta-analysis, but in this case, it was a scoping study that told us, hey, we've looked over all of the adaptation frameworks, and here are the common themes that we see. This was a wonderful kind of guidepost for us of, okay, I've got these 11 steps, and let me zoom in a little more. And here's what I need to do to adapt the program of interest. We already know the program, but it's interesting once you start diving into this, we need to understand the intervention in detail. And oftentimes, the core components of an intervention are not simply just handed to you, right? They're tested as a package. We don't know how each piece of that works. And so we had to really dig, understand the literature to understand what are these essential components of the program that we need to maintain fidelity to. We consulted and we engaged with the curriculum developers out of Iowa State, so consulted with experts. We did focus groups with existing facilitators and caregivers who had gone through the program, focus groups and interviews in both English and Spanish to hear if we're going to change this, what content should we add and how should we be adding it, and how would you like this or would you not? What would that look like? We then needed to decide, you take that information, decide what needs adaptation. We went back to the literature to see what do other substance-specific programs, how do they talk about substances? And we heavily relied on tobacco prevention literature because that has the longest history. And then we moved to adapt the program. And this is where it all came to a screeching halt because of COVID predominantly. What happened is that we had to stop delivering SFP as a state pretty much totally when we couldn't meet in person. Our state partners said, hey, we can no longer just do nothing. We have to provide something. So we really had to have all hands on deck, and we had to pivot to delivering a program that had totally been in person previously to delivering it virtually. And we had to provide the support to facilitators to do just that. So what we did is we followed that same adaptation process, but we did it for virtual. We did not do focus groups for this, but we engaged our expertise and our stakeholders to say, what should this look like? What resources do you need? We developed a toolkit, and here's just a screenshot of one of the pages from that toolkit. And then we engaged our extension partners to pilot this and tell us what went well, what didn't work well. And then we trained the broader workforce in SFP to be delivering, SFP 1014, to be delivering virtually. There were no content changes, but again, we provided this guidance for how to do this online and some additional tools. This is the poster that was shared with you in the pre-reading. You can see some outcome data related to the satisfaction of the training from the facilitators, related to the acceptability from caregivers and youth. You can see that youth, they didn't want to be online. This could be an artifact of the time we collected it, or just, we were all burnt out from being online, a little more acceptable to caregivers than it was to youth. And generally, we came up with some successes and some challenges that we had. We've done some preliminary evaluation of our virtual program and found that we do see similar pre-post changes, at least magnitude-wise. Not all of them are statistically significant, but I think it's just because we haven't implemented enough. We haven't had enough implementations of our virtual session yet. There is interest in continuing virtual. So I'm glad we did this. We actually have some sites who, even though they could be in person, are still opting to be virtual. So there is a group, an audience that is still interested in this. All right, so we took care of the virtual issue, and that's really being responsive to what those local and community needs are. So let's go back to the adaptation. So we have completed the substance-specific adaptations. We did one for cannabis and one for opioids. We did adaptations to only the caregiver and the family sessions. We were really concerned about adding substance-specific content to youth sessions for 10 to 14-year-olds and worried about any iatrogenic effects that we might have. We've trained our extension professionals and partners, and they're actually implementing these the substance adaptations now. So I just have a few, going to kind of leave with a few, what worked here? What, if I reflect on this, what worked well? And so part of this is leveraging that whole network that I showed you. So from top to bottom, or bottom to top, or back and forth, however you want to talk about it. We really have the role, the participation of faculty and state specialists, from local extension faculty, including one that I mentioned was that master trainer. We had research coordinators involved. We had local program coordinators and part-time staff who were implementing programs. I can't count the number of community partners that we partnered with to deliver, as well as some graduate students who were participating. We also leveraged our reputation among state agencies. I saw someone who's from the Washington Department of Health. We have the Division of Behavioral Health and Recovery, who provides a lot of these substance use prevention funds. And part of that requirement is a certain portion of those funds need to go toward evidence-based programs. By building on an existing evidence-based program, local prevention coalitions who are funded with that money can still implement our adapted version of SFP because we still have fidelity to those core components. And we also leverage our prevention research subcommittee, which I think is an interesting feature that we have in Washington State, which are participation between state agencies, as well as researchers at University of Washington and WSU. So we all meet together on a quarterly basis and talk to one another about what are the challenges at the state level? Where do you need more research? And from the research perspective, how can we hear your perspective of state agencies in our own work to inform the research? So it really is a two-way street. The other piece is really intentionally nurturing these community partnerships, this extension partnership, and engaging as true partners. This often means listening, being really flexible. There are times when we were not able to implement our adapted version of SFP 1014 because there just wasn't enough recruitment, because a partner dropped out, and we just had to be patient, understanding, see what we could learn, and try again next time. And that really means we need to have some open lines of communication. We also need to have really clear shared expectations, expectations around scholarship and authorship, acknowledgement of our partners. We buy out of time from community partners and our local coordinators. And then we're very mindful of how are they contributing at a state level to this work we're doing versus what are their obligations at a county level, so we're not misattributing to their time in any way. So I'm going to kind of wrap up there and share this is just part of our WSU team who's been participating in this, but there are, again, a number of other family participants as well as community partners who have shared in this process. So I'm going to pause because I've just talked for quite a while and stop sharing and let Samantha kind of get things up to speed, and I'll check the chat in case there are any questions. All right, I don't see any now, so you may be good, Samantha.
Okay. Maybe we'll take a quick movement break. Feel free to inhale and reach your arms up overhead and maybe tilt side to side. Doesn't matter which one you go to first, just getting a little bit of that lateral stretch, and then maybe squeeze the elbows down, cactusing the arms, and then just twist side to side. It's incredible how much I talk about physical activity promotion while being completely sedentary. Feel free to let the hands drop, and if it feels good to keep moving, feel free to stand up and take a break. As Elizabeth and I got to know each other and prepared for this, I said, I am never on time. So with that, I'm going to try my hardest to speak really quickly about this odyssey of mine with an extension. So I'm here to discuss how I've applied dissemination and implementation science in cooperative extension for the last 14 years, which has just been an incredible journey. So that's how we came up with this nautical theme. And I am, as was mentioned earlier, the director of my laboratory, but my background is in behavioral psychology. And when I was going through graduate school, our course was called Diffusions of Innovations. We weren't quite yet learning about dissemination and implementation science methods and measures in the same way that we're talking about it right now. But a lot of that was able to be threaded within my graduate training. So that's how I kind of have those components of my background. I am the exercise specialist of Virginia Cooperative Extension. That's what I was hired as, but I like to say I'm the physical activity specialist of Cooperative Extension, just to really integrate that it's physical activity for all bodies and in any way that suits them. And through that lens, I lead 2 statewide programs within Virginia, and they have also expanded elsewhere. And that's, of course, through a participatory approach. And I know that Dr. Laura Bayless is on, and says a lot of her work and contributions have helped us get to where we are in terms of some of these successes in these programs. So I'm going to go all the way back to where it all started. And this is pictured as my first author publication, where I was able to look at data from WAC, Kansas, which was delivered early on in the 2000s in the state of Kansas, and was developed through a participatory approach. And they said, what type of intervention do we want to offer? As Elizabeth's already mentioned, what are the county needs? What are the resources? And how might we bring physical activity to cooperative extension? Because physical activity really wasn't talked about until the turn of the century in this system. And so my PhD advisor was Paul Estabrooks. So I was able to really have that clinical lens, that community-based lens, and this burgeoning dissemination and implementation science lens. And what we found in this work was we were really focused on, why does an agent choose, or a county-based health educator choose to deliver an intervention? What are the intervention characteristics that are most attractive? And of course, using the diffusions of innovations. And of course, we found the programs were chosen because they seemed easy to deliver. They were made for the system, by the system, and they would have a high reach within their county. And within 5 years, 95% of the 105 counties of Kansas were offering this program, and they're still offering it today. They have, of course, adaptations going on, but this provided a lot of preliminary evidence in terms of reach, effectiveness, adoption, implementation, and maintenance, that this might be a program to scale out. So the next step was to see, can this program be scaled to Virginia? So Paul transitioned from Kansas to Virginia and thought, what might Virginia need in terms of adopting a program like WAC Kansas? So he renamed it FitX for Fit Extension, so that it wasn't just a WAC Virginia or a WAC Kansas or a different state name, so that we can all talk about collective impact in our statewide walking programs. Not to bury the lead, but that hasn't happened yet. But it is underway in some of our work. And so we said, so what would this look like in Virginia? And ran an adoption trial. So adoption of the program was the primary outcome. 36 county-based health educators were interested in offering physical activity in Virginia. So we randomized 18 of them to a program they were already familiar with, Active Living Every Day, and 18 of them were randomized to deliver FitX, and then see which one kind of took off within the year's time. We actually only had 2 agents deliver Active Living Every Day, but 16 agents, so the opposite, deliver FitX. And reasons for this were that it have a high reach, low resource needs, and was able to still be effective in terms of introducing physical activity, education, and behavior. And the program is still in existence in Virginia today. So that's the study that's pictured on the left, but then our complementary one that's on the right, we wanted to look at why people chose to adopt it or not adopt. So we have a qualitative analysis of adopters versus non-adopters through our semi-structured interviews, and then our thematic analysis. We were able to see that the adaptability of FitX, where they were able to offer it purely asynchronously, or go for a walk with their teams, or not. And so they were able to stick to the core elements of the program, which is offering the program to a team of people, goal setting, self-monitoring, and feedback. So those were the core elements. If you stick to that, there's other things on the fuzzy periphery, as we know, in terms of what might fit as an adaptation of the program. But active living every day, particularly at that time, was a little more strict in how it needed to be delivered. And it was what we would consider manualized. And the agents had to follow along exactly as prescribed in order to have fidelity. And that just didn't fit with what the agents wanted to be able to provide to their community. So we were able to take Walk Kansas to Virginia with the same core elements, but consider ongoing adaptations over time. Then I left and went and did a postdoc at the University of British Columbia, where I was able to work on a 3-armed randomized controlled trial. I like how I said ran it. I was a postdoc overseeing parts of it, but I wonder what Mark Beauchamp would have to say about that. So I didn't run it, but I was a part of the team, and we were across the greater Vancouver area, where we trained older adults to deliver a program for older adults. This was surprisingly still a little bit new, this train the trainer idea, and what types of training and technical assistance would a community volunteer need in order to deliver physical activity safe and effectively, and what types of implementation checklists might we use to check in on the fidelity, because we're in 3 different locations of Vancouver, and ensuring that all of the participants are getting a similar experience, because we're leveraging the older adult volunteers that I was able to train. So I was really immersed in the complexities of training and technical assistance very early on. We had about 300 older adult participants and 13 trained volunteers. So I stayed very busy during my postdoc and was contemplating what might be next. And then the announcement for my current job came up, and it said 75% with cooperative, or 75% research, and 25% of my time protected to work with Cooperative Extension. So I never knew at the time how unique that appointment was. I am the only person that we know of that through survey data of specialists that has that kind of appointment. Because I wanted to be able to study the system of extension. So 75% in research while still embedded with the system. One of our threats that we might talk about in a couple of moments is that sometimes when people think about partnering with or working with or leveraging cooperative extension, they kind of write extension into their grant and expect people to go out and do what they said, instead of being immersed in or valuing the system in its totality. The other important thing to note, this is 2014, as Elizabeth mentioned, this is when our National Framework for Health and Wellness was originally released. This is what funded my position, because this was the first time in our 100-year history of cooperative extension that physical activity was specifically called out in the United States Department of Agriculture and NIFA policy. And one of my favorite quotes from this original document is, "This same system of extension can do for the nation's health what it did for American agriculture." So it was kind of this perfect storm for me to start charting a course to say, what might we do both within Virginia and beyond? And I mentioned the within Virginia and beyond because there are only 9 exercise specialists across the entire nation. So there might be a health and wellness specialist or a health specialist, but if we think about the term specialist, but then say you do health, that's really a generalist. And so how do we give enough time and energy and support to physical activity if it's just one of many things that this specialist is trying to provide training, technical assistance, and support for? So when I was hired in 2014, I really prioritized national service and national committee involvement. And that's how I was able to really build partnerships, particularly with Dr. Kathy Gunter and Dr. Annie Lindsay, who had been already pushing for physical activity within Cooperative Extension for a few years prior to my onboarding. So two of the projects that we worked on, one is we looked at all of the strategic plans for extension systems to see how many people were the innovators or early adopters of physical activity within cooperative extension in general. And we found that very few states were saying we do support physical activity. Health, yes, but physical activity or exercise was very infrequently mentioned. And so that led us to wanting to write this paper where we provided 3 case studies of how physical activity was being promoted within Nevada, Oregon, and Virginia. So we kind of talked about our participatory approach, our target audiences, and how we leveraged what Elizabeth had showed previously in terms of the federal, state, and local components and support for physical activity. So we knew that there was initial interest, but there was a long way to go. So this is 2014, 2015 at this point, and we're trying to think through how do we start these conversations and how do we employ dissemination implementation science methods and measures to speed the translation of evidence-based interventions into practice, because we know there are plenty of physical activity interventions we could deliver. We don't want to reinvent the wheel. So Virginia Cooperative Extension is divided into 4 districts across the state, and I am physically housed in the Southeast District. And I mention that because a lot of agents who are across the state and farther away from the university feel sometimes a little less supported. So my very first year as a professor was spent in the car going around and attending individuals' programming, which many folks who do participatory action research or community-based participatory research do that, right? We know that those human connections and that human capital is so important in terms of how we lay a really strong foundation for our research efforts. I also wanted to highlight a little bit about our structure within Virginia Cooperative Extension, because a lot of times people think as a specialist, I have a number of employees across the Commonwealth who have to do what I tell them. And I really want to make sure that it's clear that I am a resource for agents, but they have the autonomy to choose their program offerings, their menu of options. And so it's really my job as a specialist to help them implement or de-implement evidence-based interventions, help them really use their time and energy and other resources wisely to be able to have that public health impact. And this is a picture of the physical activity leadership team. So on the bottom, some of my initial lab members, and on the top, some of the representatives across the state, where we would meet about monthly to talk about what do we need to do to influence physical activity behaviors across the state. So we really needed some sort of compass to guide us in terms of, what are our problems, what are our potential solutions, and how do we have an iterative approach? As has been mentioned already, we're going to assess, plan, do, evaluate, report, or any other iterative cycle that you've learned through your discipline. And pictured here is our integrated research practice partnership model, or IRPP model, that we proposed about a decade ago, that really focuses on the fact that we want to think about things that are scientifically innovative, as well as have practical implications and actionable information for our stakeholders. So we have to start at the very beginning, right? So we start at the top with our problem prioritization, and we found that the agents and my team were able to identify 2 kind of focus areas. We wanted a program for people 18 and up, and then a program specifically for people who were 65 years of age and older. And our first step was to, again, look to the literature. What already exists, what's open access, what's accessible and so open access as operationalized in the paper that, as I mentioned, Dr. Laura Bayless, who's on, was the lead author on this. We looked at programs that did not, that had really broad eligibility criteria. So anyone 65 and up could join. They didn't already have to have a specific chronic condition or be at risk for. It's just a community-based program that we could leverage within our system. And so the bottom right, focusing on our older adult population, is the example I'll weave through the following few slides. But in the upper left, just to give that shout out back to Walk Kansas and FedEx, we did want to look at walking and wheeling as a form of accessible physical activity promotion. And what we found was that a number of states were offering a version of FedEx or Walk Kansas, and there's still some more work to be done there. But today I'm going to focus on our older adult intervention going forward. So we looked to the literature, found what programs were being delivered. What we found was that Stay Strong, Stay Healthy was being offered in a number of Strong Women, Strong Bones was being offered in a number of states. Strong Women, Strong Bones was originally out of Tufts University and for osteoporosis prevention and management. However, one of their dissemination strategies was to train extension professionals to deliver the program. But because it was Strong Women, Strong Bones, not a lot of male individuals were coming to the program. So one minor adaptation was the rename to Stay Strong, Stay Healthy that's delivered in the state of Missouri. So when I was hired, so this is still 2014, 2015, building our physical activity leadership team, and then we found Stay Strong, Stay Healthy. We partnered with Steve Ball of Missouri to say, okay, what's the program here? How might we bring it to the state of Virginia? So once we were trained on Stay Strong, Stay Healthy, our agents wanted further adaptation. So we offered an opportunity to study the difference between Stay Strong, Stay Healthy and an adapted version. The adapted version is called LIFT, or Lifelong Improvements Through Fitness Together. The core elements of the program stayed the same, delivering the exact same exercise sequence because we had a lot of confidence in the exercise physiology and the fall prevention that had already been established through iterative trials beyond Strong Women, Strong Bones. And our agents, though, wanted to be able to talk about fruit and vegetable consumption because we are still under USDA and NIFA. And while physical activity was so new, they thought, but if we talked about fruit and vegetable consumption as well, it might fit within our mission, values, and resources a little bit better. And then the other thing we wanted to do was LIFT is offered twice a week for 8 weeks and focuses on strength training. But for those of you who are aware of the physical activity guidelines for Americans, we also have 150 minutes of moderate intensity aerobic activity or 75 minutes of vigorous intensity aerobic activity for people 18 years of age and older per week. So we wanted to encourage aerobic activity outside of the class. So those were the two adaptations that we needed to be successful within Virginia. So then we had to run our trials to see if we were still able to recruit and retain, improve across our functional fitness assessment by Rickley and Jones that has upper and lower body flexibility and strength, agility, and aerobic capacity. And this is starting to build our level of evidence around lifelong improvements through fitness together. So the program is going really well. It's being expanded to a couple of different states. So Wyoming comes on board, North Carolina comes on board, Penn State comes on board, and the University of Arkansas comes on board. And we start thinking about what do we need to do to continue to adapt the program and let it fit within those systems, because as Elizabeth mentioned, we're similar, but we're also distinctly different. So for example, the program in Virginia is free or has maybe a $5 fee just to let people feel like they've invested in it, whereas Penn State has a very different funding model because they actually pay instructors rather than leveraging community volunteers. So there's just different approaches, but the same program. So how it's delivered might be a little different based on the state system. So our ongoing evaluation, we have over 300 people trained to deliver the program. We reach thousands of individuals every year. And we started really looking into the data because we had really strong data in terms of upper and lower body strength, aerobic capacity improvements, and our agility improvements, but we weren't necessarily always getting our balance and flexibility improvements. At the same time, kind of like the passing ships in the night, I was doing my 500-hour registered yoga teacher training. So I'm thinking balance and flexibility isn't improving. Maybe we can now adapt the exercise sequence of lifelong improvements through fitness together. For example, one of the measurements in the Rickley and Jones functional fitness assessment is to bring your arms out to a T and then bend at the elbows, bringing your hands behind your back, seeing how close your fingertips get behind you. And that's Gomukhasana, or cow face pose arms in yoga. So now we're saying, okay, how can we provide a little bit more exercise specificity so that we can see these improvements in the balance and flexibility as well? So we said, okay, we're going to offer that as an adaptation. Another thing the agents were asking for in our decision making was, we're offering this program in a lot of rural areas. Is there any way we can offer Lift online? And we said, I think we can safely deliver Lift online. So in 2019, we're going to add the yoga adaptations and we're going to move online, and we're about to run a training, and then the pandemic hit. So we had to really pivot, because not only did our agents need training on delivering interventions online, they also needed their own self-care practices, their own stay-at-home navigating work-life flow. So we pivoted 100% almost to one of our programs called Muscle, or Mindfulness and Understanding of Self-Care for Leaders of Extension. How can we put a little muscle into all that we do? And then our other program, again, that also Dr. Laura Bayless and I are MPIs on, is PACE, or Physical Activity and Cooperative Extension. Let's set the pace. And our logo here has bright red apples and mushy brown apples, because we want to help our agents pick the good apples and understand that we want to leave the bad apples in terms of our evidence-based intervention options. So while doing physical activity breaks during other programming is great to reduce sedentary time, we might not have the clinical and statistical and public health impact that we want to have in terms of doing real direct education or policy system and environmental approaches to physical activity promotion. So that was our big pivot. We're still working on a number of pilot studies of building capacity for delivering Lift online. But one thing that might be, pertinent to share, and a little shameless plug, is that so I received earned tenure in 2020, but I didn't do anything for sabbatical because it was 2020. So I took sabbatical this year. And as Nicole mentioned in the intro, I was able to visit UC San Diego and write a book and take some time off and really think about what I want to do over the next 20 years of my career. And it's really about integrating yoga principles for mind, body, and spirit. Yes, in extension, and yes, for anyone who works in academia. I've just launched my podcast last week. It's called Higher Vibrations in Higher Education. And I have meditations related to some of our primary imbalances that we experience as academics, as well as a number of incredible interviews with academics across the career trajectory. So I have some medical students and postdocs and senior faculty members, and Dr. Gorshiko Rabin is one of the incredible guests. So there's a lot building in terms of how do I start to train the trainer for extension professionals to be able to apply yoga principles for themselves, but also lead them for the community members that they serve. And that's going to be this complete pivot within. It's not a complete pivot. It makes sense to me, but I'm charting a new course. And that's just what I've done for the last 14 years in Let's see, I checked recently and I think I'm at exactly 25 minutes. So the next portion of our conversation today is really going to lean into a conversation with all of you. As Elizabeth kind of primed us, hopefully you've been thinking about, wow, extension is so strong in these ways. And extension might have a couple of weaknesses in these ways. We have a lot of opportunities and threats. Where are blind spots? Because we're so, I said the other day, I'm like, we're in the trenches. And it's like, oh yes, we're entrenched in this work. And so it's so hard to see outside of that. So hopefully we can now engage in a brief, bi-directional SWOT analysis. To further prime the discussion, I just wanted to share a couple, two more slides. One is within the system of cooperative extension, there is a lot of tension about whose extension counts. What type of data really matters? What does it mean to be evidence-based or evidence-informed? And I think from a more clinical or research-heavy lens, there's different parameters than what our extension professionals typically employ or embrace. And so how do we work within that tension? I'm also highlighting on the right side, which I don't have the citation here, but this is the paper that I invited you all to read before the presentation in terms of us talking about there's a multi-level approach to building capacity within extension for physical activity. But if you don't do physical activity, you can also cross out physical activity and think about the multi-level approach to integrate your type of intervention. It could be financial management, it could be substance use and abuse, things like that. So we really want to make sure that we're thinking through a multi-level lens. And then the last three things I just wanted to show is that we do have a journal of extension. So if you have a study or a paper where you've been thinking about how to reach community-based health educators who have to make a decision about an intervention they might deliver, this might be a great place to send information like the reach and ease of delivery and its previous effect elsewhere and how it might fit within extension, because this is the journal that our extension professionals go to primarily. And then I just have a couple of articles cited here, like, hey Siri, what's the future of extension? So if extension professionals don't start really embracing, social media, how do we catch up and make sure that our materials are shifting with the times, and how do we stay relevant? And then the final plug is one of our papers where we introduce the REAIM framework. We've been introducing the REAIM framework for 14 years to extension, but this is one really practical paper where we have a table with the dimensions with specific questions, and there's a health equity question to really start to get extension professionals thinking in this way, which was one of the precursors to our current framework for health and wellness that has that equity lens really highlighted. And with that, we'll pause for any questions. I'm seeing lots of things in the chat. Let's go to that, and then we'll pivot into our SWOT analysis, where we're hoping we can implement the whiteboard use. So let's see how well we do, but we'll visit the chat box now.